Let's talk about something you do every single day. Turning a patient, changing a dressing, explaining a new medication. Have you ever really thought about how those simple actions connect to the hospital's entire multi-million-dollar budget? Well, today we're going to pull back that curtain and show you exactly how your everyday care has this huge direct impact on not just patient safety, but the hospital's financial health.
I want you to just let that sink in for a second. This isn't just some catchy phrase. It is the absolute reality of healthcare today. So in this explainer, we're going to follow the money. We're going to see exactly how the things you do at the bedside trace a direct line to the hospital's bottom line.
So, here's our game plan. We'll kick things off with the big picture of healthcare money. Then we'll get into the different places where care happens. After that, we are going to dissect what happens when things go wrong, these never events. Then we'll talk about getting patients out the door safely, what happens next, and wrap it all up by focusing on your massive role in this whole system.
So you might be asking, how did we even get here? How does turning a patient have million-dollar consequences? Well, it all comes down to this giant shift in how hospitals make their money. The entire economic model has been turned on its head.
Okay, think about the old way, fee for service. It was pretty simple, right? The more stuff a hospital did, more tests, more procedures, you name it, the more money they got. But now we're in a pay-for-value world, and the whole game has changed. Now the hospital gets paid for good outcomes, for actually making the patient healthier and keeping them from bouncing right back. And that is exactly why your care is now a core financial strategy.
So the very first step in creating that value is just getting the patient to the right place to begin with. You, as the nurse, are basically the air traffic controller for the whole healthcare system. But this brings us to one of the biggest points of confusion for students: the difference between the setting you're in and the action you're taking.
Let's just take a quick look at the whole landscape. You can see there are 6 main settings, and it's really a spectrum. It starts way over here with preventive care, getting your shots. Then it moves into the intense, acute world, the ER or ICU. That's your secondary and tertiary care. And finally, it transitions out to restorative care like rehab or continuing care like a nursing home. The whole point is, each setting is purpose-built for a specific patient need.
Now this, right here, this is a classic exam trap. So listen up. The level of care is just the building you're standing in, the ICU, for example. The level of prevention is the action you are taking inside that building. So yes, you can absolutely be doing primary prevention, like turning a patient to prevent a pressure injury, while you are physically inside a tertiary care setting. Do not confuse the place with the practice.
And if that's still a little fuzzy, this analogy makes it crystal clear. Think of a fire station. That's the setting, right? It's a high-level acute resource, just like an ICU. That's tertiary care. But when those same firefighters go to a school to teach kids stop, drop, and roll, what are they doing? That action is primary prevention. They are trying to stop the fire from ever happening. It's the exact same logic in nursing.
Okay, so we know where we're providing care, but now let's dig into what happens when that care, when it goes wrong. When our actions, or sometimes our inaction at the bedside leads to real patient harm, it sets off this whole chain reaction of both clinical and financial problems. This is where we get into something called a never event.
And this is the term you absolutely have to know: nursing-sensitive outcomes. See, a good outcome is a team effort, for sure, but certain bad outcomes are so directly linked to the quality of nursing care that they're basically a giant red flag for a nursing system failure. And these failures have names. They're called never events for a pretty simple reason. They are considered totally preventable. They should never happen. And just look at the root causes here. A stage 3 pressure injury, that's directly tied to a failure to turn a patient. A CAUTI, that's linked to a break in sterile technique. Now, look at that third column. This is where the money comes in. For every single one of these, the government, through CMS, basically says, hey, you caused this problem, so you get to pay for it. The hospital gets hit with a direct financial penalty.
So let's trace the pathophysiology here. It all starts with one simple root cause. A nurse doesn't reposition an immobile patient. This leads to the disease, a stage 3 pressure injury. But that disease has a symptom that you won't see on the patient, you'll see it on the hospital's budget. And that symptom is that CMS, the big payer, either reduces or flat out denies funding for that patient's care. See the chain? One bedside failure leads to patient harm, which leads directly to a financial penalty.
All right, so we've kept the patient safe inside the hospital's four walls, but the moment they transition out of the hospital is actually one of the most dangerous times for them. Preventing them from coming right back means we have to absolutely master the discharge process. And luckily, there's an evidence-based protocol for that.
It's called the IDEAL framework, and it's basically a checklist for a safe handoff. It's so much more than just rattling off instructions. It's about including the family, discussing the must-knows like medications and warning signs, educating in simple, plain language, listening to what the patient actually cares about, and, this is the most important one, assessing if they actually get it.
We've all asked this question a million times. It feels helpful, but honestly, it's a safety trap. Your patient might be totally overwhelmed, or maybe they're embarrassed to ask, or they just don't even know what they don't know. So when they say no, we get this false sense of security that they understand, when really, they could be completely lost.
So what's the solution? It's the A in IDEAL, assess. And the tool you use for that assessment is called Teachback. The best way to think about it is like a diagnostic test, right? You wouldn't guess if a patient has pneumonia. You'd order a chest X-ray. In the same way, you don't guess if a patient understands their discharge plan. You ask them, can you tell me in your own words what you're going to do when you get home? It's your final safety check, and it's the single most important thing you can do to prevent a readmission.
Okay, so once that patient leaves, their journey is not over, not by a long shot. They step into this whole other world of post-hospital care that can be really confusing, but the goals are actually pretty distinct and really important to understand.
So there are really two main paths they can go down. The first is restorative care, and the goal here is recovery. Think about stroke rehab. The whole point is to get that patient back to their highest possible level of functioning. The other path is continuing care, and here the goal is maintenance. This is for patients with long-term chronic conditions who aren't really expected to get fully independent again.
Now, within that continuing care world, this is a must-know for any exam: palliative versus hospice. The absolute key difference is this. With palliative care, you can still be trying to cure the disease. Think of it as comfort care plus treatment. Hospice, on the other hand, is only comfort care. It begins after all curative treatments have stopped. It's the difference between living well with a disease versus living comfortably until death.
So, as we start to bring this all together, you can really see it, right? Every single step of a patient's journey, from the moment they're admitted to long after they're discharged, is just profoundly shaped by nursing care.
So let's lock in the key takeaways here. Number 1, discharge planning starts on day 1. Number 2, those never events, that's where your care hits the hospital's wallet hard. Number 3, stop asking, do you have any questions? Always, always use Teachback as your final safety check. And finally, knowing that difference between palliative and hospice is crucial for making sure your patients get the dignity and the care they deserve at every stage of life.
And we come all the way back to this really powerful idea. Look, when a never event happens, it's not about pointing a finger at one person. It's about recognizing that the nurse is the final, critical safety net for the entire system. Your attention to detail, your actions, your advocacy, that is what makes the system safe.
And that brings us right back to where we started. In the world of healthcare today, quality, safety, and money are all tangled together. They're inseparable. And nursing, well, nursing is the thread that weaves through all of it. Every single action, from turning a patient to teaching them, has a ripple effect. And knowing that, the only question left to ask is, what will your impact be?